This is a talk about not only complications, but what happens after the complication. Even if you fix it and you do everything right, the dreaded word of litigation. If you weren't here yesterday, I'm going to plug this again. I'm the course director of the 9th International Otolaryngology Underwater course that the Seattle Science Foundation is the course sponsor of. And it's down in Jamaica, October 24th through 27th of this year at beautiful Half Moon Bay Resort. It covers all aspects of ENT, rhinology, otology, laryngology, head and neck, facial plastics, sleep surgery. If you don't have to scuba dive, but a lot of us do, you can snorkel, sit on the beach, golf, all those things are strongly encouraged. Anyway, I'm not an attorney. I don't play one on TV. I do serve as an expert witness and usually do 1 to 2 rhinology specific cases per year. I get asked to do otology cases and I always refer them to Doug or Cliff, Gabby, and people who know about that. So I think staying in your wheelhouse is really important. These are real cases, and I've changed some of the details to protect the innocent and the victims and protect the guilty as well. But they're humbling, and you look at some of these cases and you think, yeah, that could have happened to me. So I'll talk about some cases and what was done right, what could have been done better, and then how to avoid the litigation, because as Brad showed, we can't prevent complications. And complications doesn't mean you did something wrong. Doesn't mean you were negligent, but there are things that lead up to it and certainly things after that can help you. In 2018, there were 11,500 medical legal suits filed against physicians in this country, over $4 billion in payout. And that's why you see, when you're driving down the highway in Texas and Florida and other states, you see billboards of medical legal attorneys wanting your business, not our business, other people's business. In a 10-year span, this was published in Laryngoscope just a couple years ago, there were 1,217 ENT lawsuits identified. 10% of those lawsuits ended up going to court. So good news is 90% of them settle or don't go on beyond when it was, so they can get retracted. And if you look at the distribution, it's over 25% is in rhinology, 17% in head and neck, and then it goes down after that. And the error, what was considered the error, was improper surgical performance, one of the main key things, also known as negligence. Failure to diagnose, treat, or refer. That's another big one, when people just delay the diagnosis or the correct diagnosis. And then when you look at complications, you would kind of think that that would be the biggest one, but it's only 6% of cases were related to true complications. The most common surgeries, anybody name one of the 3? FES, sinus surgery, yes. Not number 1, though. We're playing Family Feud here. So number 1, I'll go with, oh, it is. Sorry, I thought it was number 2. I haven't looked at my slides for a while. Sinus surgery, yeah, as Brad said, orbit injuries, CSF leaks, tonsillectomy, number 2, and then who knows the last one? I can't hear any of you. So recurrent laryngeal nerve injury with thyroid surgery. So here's a case of negligence. This is a 32-year-old gentleman complained of a rotten smell in his nose, sinus congestion, failed to improve with 2 courses of antibiotics, went to see the ENT. ENT saw them, shared decision-making, said we could do surgery, let's do more medical therapy, did antibiotics for 30 days, a prednisone taper, and wanted to get a post-treatment CT scan. All very reasonable. Got the CT scan, the ENT wrote down in their clinic note, left maxillary and ethmoid sinus opacification. The radiology report says opacified left maxillary sinus, possible polyp in the left ethmoid sinus, osseous structures are normal, okay? Moving on, because you're in a busy clinic. So the sinus surgery, we're gonna come back to that, don't worry. Sinus surgery was performed. Bilateral full house, FES, full house, all sinuses done. Septoplasty, turbinate reduction. Intraoperatively, the surgeon recognized orbital fat. So good on the surgeon, they recognized it. In the note, they said, I avoided the fat throughout the rest of the surgery. In the pathology report, though, it showed sinus mucosa as well as fragments of fat and skeletal muscle. So that's a problem. The result of the case is that the patient had permanent diplopia despite medial rectus repair ×2. So let's go back and look at this. So if we zoom in on this area, That's not ethmoid sinus disease, that's orbital fat. And you can see that this patient had a prior blowout fracture into the ethmoid cavity. And if you look down here, you can see it again. And it's a little tough to see with the lights, but you can see there are actually two different colored densities of gray. So orbital fat does look different than sinus disease on this CT scan. So what could have been done different? Review the CT scan a second time. You know, we're in busy clinics, you're scrolling through the CT scan. That, I can see how someone would see that as ethmoid sinus disease. Clearly, the radiologist who's getting paid to read this scan thought it was ethmoid sinus disease or a polyp. Take the time. Every time you're going to operate, either the night before or the morning of, go back when it's quiet, when you're in your office, not on a clinic day, and look at that CT scan again. Things that were done really well. The surgeon did identify the orbital fat, actually thought about retrobulbar hematoma, contacted the oculoplastic specialist, which was actually in the next room, and they came in and tried to reattach the medial rectus. But the outcome's pending, so we'll see. That's one case. Here's another case about improper surgical performance. 55-year-old gentleman, CRS with nasal polyps, failed to improve with appropriate medical therapy. Complete sinus surgery was done with image guidance and woke up with this. Now, I'm not going to go over all of these slides because Brad did a great job of retrobulbar hematoma, but I do want to go over the time course. The surgeon was called from the PACU, so the surgeon's already back in the OR scrubbing on their next case. That surgeon did not check on the patient after their surgery. The nurse documents left eye is swollen, it's painful, and the patient has blurry vision. Hour and a half later, the surgeon finished his case. He went to the PACU to see the patient, orders a stat CT scan. That's it. 30 minutes later, the radiologist pages the surgeon. The surgeon's in the next case. The pager's going off. No one's returning the pager. Does that ever happen to the residents in the OR? Right? This happens. Page wasn't returned. 2 more attempts to page the surgeon. They finally returned the call. The surgeon was informed of the retrobulbar hematoma. Surgeon had oculoplastics paged. They weren't in the OR that day. Optho finally saw the patients 30 minutes after that, now 3.5 hours after the initial surgery ended. So lateral canthotomy was performed beautifully as Brad described. And the end result is the patient had severe left-sided vision loss. They settled out of court, but the surgeon and the health center were both named. So it's essentially compartment syndrome of the orbit. You need to decompress it. Here's the one thing that I want to add to what Brad said. There was this study done on unfortunate rhesus monkeys. If the central retinal artery was obstructed for less than 100 minutes, there was no permanent damage, no permanent vision loss. And I don't know how you get a monkey to tell you what the vision is, but they do it, okay? If it was obstructed for 4 hours or less, or 4 hours to 100 minutes, there's a variability in the vision loss. Over 4 hours, all of those eyes had permanent vision loss. So you have time. You don't have a lot of time. You know, you got 100 minutes, so think about that. Brad covered this already. I'm going to skip it. This is something that, like, when I'm looking at cases, there's always something that comes up, oh, this could have been done, this could have been done. And so these are things that can be done with a retrobulbar hematoma, in addition to taking out the packing, considering going back and after the lateral canthotomy. If that's not enough, you can do a medial wall decompression. You don't have to have a tonal pen. I've heard that defense, I didn't have a tonal pen. If the eye is taut, if it's coming out of the skull and you can't depress it and they have blurry vision on that, you don't need a tonal pen to tell you the pressure is too high. Just do the canthotomy, cantholysis. But all these different drugs can be done. They can all be done to decrease the pressures and improve blood flow. So I keep this on a note on my phone, because if this happens to you, you're probably going to not be thinking as mentally clear as maybe you ought to be, and it's nice to have things written down step by step. What are you going to do in this problem? And in fact, it's, you know, I would suggest taking it one step further. For each significant complication, especially if you're in an ASC, and maybe it's one of your partners who isn't a 100% rhinologist, what should you do with this potential complication? I'm going to skip this one in the interest of time, and then we're going to go on to this one. A case of lack of medical necessity, lack of consent. 42-year-old female with right-sided facial pain, A sinus CT scan was performed. She has a severe septal spur, which you can see on the scan. And the diagnosis was mucosal contact headache syndrome. This is pain that's thought to be originated from the release of substance P if one structure in the nose is contacting another structure where it shouldn't be contacting. So that's a nice point. And I'll tell you, I see these patients on occasion. 50% of the time, if you look in the nose and you see this, they feel fine. They have zero symptoms. And you're like, do you have any pain on the side of your nose? No, I feel great. So that's why it's a syndrome. This is not pathognomonic for having this condition. So the surgical consent was interesting. It said septoplasty, great. Left inferior turbinate reduction, great. The surgery was performed, septoplasty, bilateral inferior turbinate reduction. And then the patient came back complaining of a dry, painful, crusty, congested nose, diagnosed with empty nose syndrome. The right-sided facial pain, unfortunately, was no better. So under deposition, the patient said, the surgeon never called me back when I called with my complaints after surgery. And then this is a video deposition, and the patient was crying, said, I saw the surgeon 2 weeks after surgery. I was really hurting. My nose was horrible. She told me to come back in 3 months. So they settled out of court. The surgeon wasn't named in this, but there was no discussion of empty nose syndrome, of a dry, crusty nose, of continuing pain after surgery, or even worsening pain after surgery. So be careful with operating on pain. And the plaintiff expert stated that there was no reason for the contralateral turbinate reduction. And that was the question. It wasn't a nasal congestion. It was for that mucosal contact headache syndrome. So why did the surgeon do the contralateral turbinate, especially when the consent said only for unilateral? What could have been better? Could have been nicer, could have been responsive to the patient, and know that consent is a process. It is a conversation. It doesn't all have to be documented, but you have to have that conversation with the patient, and ideally you document the key points of the conversation. There's a lot of turbinate cases in here, and one of the med students was an attorney before he was a med student at the university, and I did this study, and there's 39 cases went to court for turbinate surgery in this giant span of time, but these are the cases that actually went to court. There's a lot of other cases that don't get reported to these legal databases. Fortunately, the surgeon prevails in 87% of cases, but that's technically one in the win column for the surgeon, but the impact to their life is tremendous. The amount of time they have to take out of their practice, the financial pain, the emotional pain. Some surgeons retire and just quit medicine when a lawsuit hits. And that's the reality. Most surgeons over the course of a 35-year career will be sued once in their lifetime. Here's another one, and this is a lack of consent and even battery. Remember, battery is when you're actually, it's not assault. Assault is like threatening to hurt someone. Battery is when you are hurting somebody. That's why we get informed consent, by the way, so we don't commit battery on patients. 52-year-old female, she wanted a cosmetic rhinoplasty. This gal was consented for a rhinoplasty. The consent also states and any associated procedures deemed necessary. The patient read about empty nose syndrome online. She called the surgeon's office 2 days before her surgery and said, I absolutely do not want my turbinates touched. It's documented in the chart by the front desk staff. Surgery was performed, open septorhinoplasty, bilateral inferior turbinate reductions were performed. Post-op, the patient came back in with nasal pain, severe crusting, dryness, empty nose syndrome was diagnosed. She went on to have 2 different revision surgeries by other facial plastic surgeons. This is where it gets interesting, more interesting. May 2nd of this a couple years ago, which was 6 months after the initial surgery, the patient called the office and said, hey, can you send me my records? So they said, sure. They sent the records with the consent form. A month later, she filed a lawsuit. Literally about a couple weeks after that, the patient's attorney's office requested the formal records. And so the medical clinic sent in the records. Okay, so now 2 sets of records have been sent off. A year later or so, the surgeon was at his deposition, and they showed him the consent form from May 4th, the one that was sent that the patient requested, and it said rhinoplasty. And then they showed another consent form from when the attorney's office requested the medical records, and all of a sudden it said rhinoplasty plus septoplasty and inferior turbinate reduction surgery. Immediately, the surgeon states they don't feel very well, and he left the deposition. The case was settled out of court, and the State Medical Quality Assurance Committee paused their medical license, and criminal charges are pending. So point of this is don't alter the medical record. It's much harder with EMRs, but it's not. I've seen cases where surgeons go back and they make an addendum thinking that that'll change the note, but literally every click, every page you open up in the medical record is captured. And I've seen cases where they'll ask a staff member, have you gone back and looked at the record? The staff member will say, oh, no, I haven't gone back to look at the record. And they'll say, well, what about these 16 times over the last 2 months that you went back and looked at this patient's medical record? So just know that the EMR is tracked. That's the take home for that. And then finally, this last case is interesting, and then we'll do a couple other like what not to do, or what to do. So unilateral nasal congestion. This one's interesting. 36-year-old guy comes in, and he's kind of this surfer guy. And he had surgery 4 years ago in Virginia. And I put the scope in his nose. It showed a lot of inflammation in the ethmoid cavity. And then I got a CT scan. I'm like, that's kind of interesting. There's something up there. And you can see that metallic lucency in the left ethmoid system. And so I was pretty excited to go to surgery with this patient. Got a 3D recon just for fun. Looks pretty interesting, right? And so intraoperatively, using the shaver just to kind of expose this purulence, but then there's something else in there. And in a second, you're really going to know what it is if you don't know what it is already. And there it is. It's that metallic string off of a 1/2x3 cottonoid. And so it's like, all right, well, this is one of my residents, it's actually Dr. Lee, she was doing this with me, and there's a point where she pulls a lot of it out, and then the rest wouldn't come out. And it wouldn't come out because really right where this is on the left side, right where the lamina connects to the skull base, the bone grew around it. So I figured I would just drill it out, and, because I don't know, can you leave that in the body or not? So drilled it out and used my otology skills that are long gone now to try to blue line it. That's the most otology I know, Dr. Rains, and pulled out the rest of it. And things went fine. No CSF leak or anything like that. So here's the interesting part is, and that all looks good. All right, so I called the original surgeon, and I think it is a nice courtesy if we see a complication. I think it's nice to have that one-on-one conversation with the surgeon. I told him, hey, this is what happened. He called the patient and apologized. No lawsuit was filed. I saw the patient back, and the patient's like, yeah, that guy's a good dude. He liked him. No lawsuit was filed. I mean, that's a retained foreign body of a long time. So the final message here, don't be greedy. And this is in the U.S. State Attorney's Office, the Department of Justice here. North Carolina physician faces charges over $46 million in Medicare billings. Anita Jackson, she's the top balloon artist in the country, performed over 1,200 balloon procedures on 700 patients, and somewhere about, I believe her office has bought 35 balloons. She reused the balloons numerous times, fabricated medical records, somehow is being charged with aggravated identity theft and mail fraud, and faces over 10 years in prison. 20 years in prison for the mail fraud, 10 years for making false statements and things like that. So, yeah, is this a one-off? No, it's not a one-off. The Northwestern Georgia Clinic is paying over $1.2 million for reusing single-use balloons. What I thought was interesting, I took it a step further and I looked at this clinic's Google reviews, and they're over 4.5 stars on Google. They're nice people, evidently. I don't know who they are. But it's something that, don't do it. It's simple as that. Just don't, please. So how do you avoid these medical legal lawsuits? We know we can't avoid complications or bad outcomes. It happens. Top 3 reasons for patient filing a lawsuit. The patient wants to know what went wrong. They don't want to feel like the information wasn't relayed to them. They want to know who was responsible. Who did it? It's harder when it's one of our residents. We want to protect them as much as possible. And they want to make sure that it doesn't happen to somebody else. So develop trust, communicate, spend time with the patients, use an after visit summary. Give them the information they need. At least you give it to them. Doesn't mean they read it. or watch the video, whatever it is, but at least provide them the information. Chart the reasoning behind your treatment strategy. It's really important to see the thought process. Did you give them an option, or did you tell them what was necessary, what they needed to do? And then refer. Don't be hesitant to refer to someone with who has more experience in a challenging case. There are 38 states, this is now a year old, so there's hopefully more, that have I am sorry laws, which means if you apologize to the patient, that is not admissible as guilt in court. So say you're sorry. They want to hear that. I'm very sorry this happened to you. I'm going to be with you step by step and do everything we can to fix this problem. I'm going to get you in to see whatever specialist or whoever it is, within a short amount of time. And you call your friends and you do everything you can to help them out. Be available. This is not a patient, whatever the complication is, this is not someone you see back in 3 months. This is you see him back every week until things start to get better. Kill them with kindness. They got to know that you're on their side. Just be nice to people, be respectful, communicate clearly, document your reasoning, as I said, and recognize that we all make mistakes. You're all going to have complications. I've had my complications. It's humbling, but that's the reality of what we do. So with that inspiring message, any questions on this before Dr. Madison comes up and tells us about how we can code? Yes, Kate.
Just got a quick question. Would you recommend, in your experience, having like a dedicated FS consent form that lays out like some of the big things, or is that more put at some risk?
There's different strategies, and different attorneys will tell you different things. So the question is, if you didn't hear it, do you want a dedicated FES form that talks about all the different complications, yes or no? I think it's important to have information available to the patient that talks about those things. I don't think you have to talk about every single complication. Again, the challenge is the task is to have that conversation with the patient. My consent form is very vague, but the information I provide to them and the information that the American Rhinologic Society has for members to give to their patients talks about those complications. So no, I don't think it's important to have that on your consent form, but I think it's important that you document in your note that you had the discussion, assuming that you did have that discussion with the patient. All right, literally everybody here has said how excited they are to hear